Praveen.
Praveen will join. Dr. Rajesh Bogla will not. I am covering his points also a little bit.
Rajesh Sinha.
Rajesh is already here.
Will join.
Good evening, sir.
We are live.
Hi, hi.
Yes, sir.
Yeah, good evening, Rajesh. Ma'am, we are live.
तुम्हारा वीडियो देख रहा ना? Yeah.
Live.
अब पता लग रहा.
Ma'am, we are live.
Good evening, everyone, and we welcome everyone to this webinar, which is a public webinar on the keratoconus. And basically, this is a webinar on the eve of World Keratoconus Day. As we commence this webinar, which is under the aegis of All India Ophthalmological Society, Cornea Society of India, Indian Society of Cornea and Keratorefractive Surgeons, and Eye Bank Association of India. I would request our President, All India Ophthalmological Society, first to say a few words.
Thank you, Namrata. You see, and good evening to everybody. And I thank all these people who have joined in. I actually feel very embarrassed to be present, in front of great cornea people, because I consider myself a foreign body here, and amongst all you corneal colleagues do great work here. But believe me, I'm very happy to see that you see on the eve of World Keratoconus Day, it is the 4 societies who have come together. AIUS has joined hands with the Cornea Society of India, SCARES, represented by Rajesh Sinha, then Eye Bank Association of India. All of you, have got together for this great webinar. The aim of which is, I think, World Keratoconus Day was started. I was just going through the Google. Was started by, you see, in US by National Keratoconus Foundation around 6 years back, 2016. Correct me if I am wrong. I don't know, but it was started by National Keratoconus Foundation. You see, because technology has improved today so much that today keratoconus is considered to be a treatable and manageable condition. And you see, previously when we were residents, keratoconus, we used to see a lot of patients of keratoconus losing and coming with high drops. Penetrating keratoplasty was the only thing which used to be done. But today technology has so much, and we have improved contact lenses. Then orthokeratology, then C3R plays a very big role. So I hope and I think that all you corneal expert and keratoconus experts will deliberate upon the various aspects of keratoconus, and this will ultimately help raise public awareness about this manageable conditions. So with these few words, you see, I'll hand it over to all you experts, led by JST himself. Dr. Basak has also joined, Rajesh, Namrata, and Himanshu, and wish you all the very best. Thank you.
Thank you so much, sir. We have with us on the program today the chairpersons, Dr. Lalit Verma, sir, the President of All India Ophthalmological Society. Dr. Harbans Lal, the President-elect of All India Ophthalmological Society, would be joining very soon. Dr. Samar Basak, the Vice President of All India Ophthalmological Society and the past President of Eye Bank Association of India, as well as the Cornea Society of India. Then we also have Professor J.S. Titial, who's the Chief of RP Center, All India Institute of Medical Sciences, and the President of Indian Society for Cornea and Keratorefractive Surgeons. Dr. Parihar, who's going to be joining soon, the President of Eye Bank Association of India. Dr. Himanshu Matalia, the President of Cornea Society of India. And we would be going through the various talks. Epidemiology and diagnosis of keratoconus will be covered by Dr. J.S. Titial. Collagen cross-linking and little bit about surgery would be covered by myself. Dr. Rajesh Sinha would be covering the intacs in keratoconus. Dr. Himanshu Matalia will talk about visual rehabilitation in keratoconus, and Dr. Praveen Krishna, who's the Secretary of the Cornea Society of India, would be covering the new evolving innovations which have happened in cases of keratoconus. I would request Professor J.S. Titial to say a few words before we commence the webinar, and then Dr. Samar Basak before we finally start the deliberations.
Yeah, thank you, Professor Namrata. In fact, it's, I think, one of the nice program for a public to understand a disease which is not very, very common, but those people who suffer, it is suffering for those patients. So we need to know about this disease named as the keratoconus, and which has a huge impact on somebody's life, because it is, we all know, it is seen in a younger age group. Once you suffer from this disease, we can understand how much agony a patient would undergo. With that, the entire family also suffers. And I think we need to educate the masses, not only the ophthalmologists treating these group of patients, to the entire public also needs to know what is this disease, who are those people who are at risk of developing these disorders or disease, what are the various options we have, because a lot of myths going around in the public regarding various treatment and the actual indication of doing those treatment for these patients. We have seen so many patients running to us saying that I'll go blind next day if I don't go with this treatment. So those are myths which people don't understand correctly, and sometimes the information which is passing around in a community, sometimes through the various internet type of, we can say, knowledge, may not give a true picture to the public. So I can appreciate the efforts of AIOS, that is our largest body in the country, All India Ophthalmological Society, headed by Dr. Lalit Verma and Dr. Harbanslal, Namrata, and other people. And they have included the right group of people. Those are various people working in this field, the Cornea Society of India, the Eye Bank Association of India, and ISCARES, and the other institutions which are doing a great work in this field. So I know that this session is going to be important for our people, public who are joining us. Even for those people who are doing day-to-day practice in ophthalmology, they'll also benefit from experts which are sitting here. So I can really understand this is a very, very important aspect of actually celebrating, I'll say celebrating, or putting information to public in this Cornea Day, Keratoconus Day.
Thank you, sir. Dr. Basak, sir. Sir, you're muted. Sir, you're muted.
Thank you, Dr. Namrata and our Lalit Verma sir, Dr. Titial, Himanshu and Rajesh, and all other who are viewing it. So keratoconus, as Professor Titial has already mentioned, it is a burden today for younger group of people, because we are detecting it more because of more instrumentation in our hand, and we can actually catch them very young, the early stage, and the treatment will be much less difficult at those times. So this is a very good area to cover by the different experts, from epidemiology to different kind of treatment to surgical part. And we always used to say that to the patients and their parents are more important here, that it is a disease of lifetime. We will check time to time, so follow-up is very important. So they will cover all the aspect, and when the surgery will happen, again the follow-up before that also. So we are covering in a great subject on a very, I'll be said, this is very important day for cornea people, for eye people. It is important for optometrists, opticians, primary eye care physicians, secondary eye care physician, and of course those who are working with this field. And it will be very nice, we will cover this subject. I hope the public education will be very, very helpful. Thank you very much.
Thank you, sir. Dr. Himanshu, would you want to say something on behalf of Cornea Society of India?
Thank you, Dr. Namrata. Thank you, Dr. Verma. I mean, for celebrating such kind of a specific disease on a national forum is just amazing. What I like about this thing is that we expect patients to learn from different places, but we seldom provide them proper information. Now here, our parent body, All India Ophthalmic Society, has taken this opportunity to create a content and create information for everybody, where they can get the real information and can get it from the mouth of experts, and which is really amazing. And I really thank All India Ophthalmic Society to take up this challenge, and really happy to be part of this. Thank you.
Manshu, Rajesh, would you want to say something before we begin Professor talk?
No, I think it's a wonderful initiative, and I would, like others, I would like to thank all the organizations which have come forward to increase the awareness amongst not only the patients, but also amongst the general physicians, the general ophthalmologists, so that we know how severe this condition is, and why this, certain patients do require screening as well as prompt management. So thanks a lot for this initiative, and appreciate them.
Thank you. And now I would request Professor J.S. Titial to give his talk on epidemiology and diagnosis of keratoconus. I think which is most important, because when the patients get labeled as keratoconus, then they run helter-skelter to know what are the treatment options. Sir, you are muted. Sir, you are muted. Sir.
Okay. Now?
Yes, sir.
Hello?
Now fine. Yes, sir.
Okay.
Yes.
Thank you. I think to begin with, I think it is, again, I would like to welcome everybody who joined us today for this public meeting on keratoconus, understanding the disease and this treatment which are available for various people suffering from various stages of keratoconus. Like to thank all the people who are associated in today's evening program. I think whenever we talk about a disease, it is important us to know what is the actual volume of patients in our country world over, and how do we pick up these patients for a subsequent treatment. So my job is simple but difficult also, to make people understand what is keratoconus. The keratoconus has two words in this. Keratoconus has two things. One is cornea and the other is a conus. That is a cornea getting in a conical shape. So both Latin and Greek words are combined into this. Normally, the cornea is a spherical structure, which is transparent. If you see the below left-hand side picture, spherical, transparent, which is the largest magnitude of a lens which focuses the light to the retina from where we see the image. And once this gets distorted by the disease process like keratoconus, the image can also get distorted because of conical shape. So it is a very slowly progressive disease because of a thinning happening in the cornea and weakening of a cornea. Slowly the shape also changes, and that will distort the vision because there will be induction of refractive error, which will normally we call myopia or short-sightedness. Along with that, there will be a cylindrical power also coming, which we call as astigmatism. And to begin with, this astigmatism or cylindrical power is regular, which is corrected. As the disease progresses, it becomes irregular. Once the surface becomes irregular, the image also gets distorted. You can understand it's like a lens or mirror. If the mirror is absolutely clean and sharp, the image is very, very sharp. If the mirror gets distorted, then image also gets distorted. And that is what happens in a keratoconus disease. The lens of eye, that is anterior part of the eye, which is cornea, gets distorted because of a disease process with a chronic progressive disease leading to thinning and irregular astigmatism happening. What is the prevalence? How many people are suffering from this disease across the world? If you see this bar diagram, there are different countries that have been demarcated here. You can see the country like India or some of the Asian countries have a higher prevalence of disease compared to other countries where we have a less, like a USA, Denmark, Russia has a lesser magnitude of problem for these patients. So there's a definite change in a profile of a patient in terms of prevalence wise in a various part of the world. In a larger magnitude, I think this is one of the most recent study published, a meta-analysis done, published recently in a Cornea Journal, which has nicely depicted, looking into all the studies published in the literature, what is the prevalence of disease across the world. It is around 0.13% if you look into entirety of keratoconus patient in the world. But we see India, you can see the color wise, the red indicates is more prevalence and the lighter color indicates a less prevalence of disease. India and Middle East countries have a highest prevalence of this disease, which is more than 2.3%. The Western world is very less, 0.04 to 0.05%. But if you see, these are studies which are published through the patient coming to hospitals. So it may not entirely depict the scenario in the masses, in the community as such, because we don't have some sort of a screening study done in a population. But it directly reflects to a patient who require a treatment or who come for a various other procedure and they are picked up by the keratoconus. So this is a good indicator that how many people are suffering from keratoconus. With this diagram, we know that there's a higher prevalence in a country like India or a Middle East. Then you can see China, other parts of the world have a lesser incidence or prevalence in these diseases. In terms of a gender-wise, both females and males have an equal predilection. Sometimes you see more in one particular race, but there's not much of a difference in a sex-wise. It is normally a bilateral disease. Sometimes there may be asymmetry in the two eyes presentation. One eye may have a slightly more advanced disease than other eye. It's very rare to have a unilateral involvement of one of the eyes. The average age of diagnosis or a patient coming to a hospital is around early, we can say late teens or between 20 to 30 years. But in India, it is seen a much younger population than the other parts of the world. So we see younger patients coming to us as compared to worldwide, if you look into age group or presentation of people with this disease. Ethnicity also, as I talked about in the prevalence, India, Pakistan, Bangladesh, there the chances of people suffering a keratoconus is almost 5 to 8 times more than the other countries. The ethnicity also has a significant role in the prevalence of disease. Therefore, we are much more, you can say, if you look into hospital stats or data, we'll see more keratoconus patients than if you are practicing in Russia or USA. There's a definite family history in some group of patients. Various studies will quote around 5 to 20% of cases may have a family history of keratoconus there. Because this is a very, very important understanding for a people. If you have somebody having keratoconus in the family, there are definitely more chances of keratoconus disease coming in their siblings or subsequent generations. So this has impact on our counseling of these people also. So a study which we did in our RP center in way back in 2004 or 5, we saw around 5% of people coming to RP center had a family history. Normally, keratoconus we know is a sporadic disease. It might come up without having any association of a disease happening in these cases. But we know that there are some systemic disease or syndromes where this disease can be associated, like keratoconus, or there can be a local eye disorders which may also predispose or may be associated with this keratoconus. The important disorders or a syndrome which are very commonly seen are a Down syndrome, Turner syndrome, which are the many other systemic features apart from the eye disease happening in these cases. As far as eye disease concerned, allergic disorder, which is very common in a younger age group in India, which we call a vernal keratoconjunctivitis, or some congenital disorder like aniridia, where we have lack of uveal tissue in these patients. Some other associated disorder in the retina also. We all know, people know retinitis pigmentosa, where people have night blindness and slowly they go blind. So sometimes these people can also have keratoconus with associated with these disorders. So how does this happen? What is the basic pathology of keratoconus in people suffering from disease? So basically, if you look into cornea, it has a multiple layers, right? From the outer surface epithelium, you can see here, just below that is a Bowman's layer. The larger area is a stroma. Then you have a deeper descendant layer in endothelium. So basically, these are 4 or 5 layers which constitutes the entire structure of cornea. In the disease process of keratoconus, there's a thinning happening in the stromal area because of a certain area getting deficient. That is a loss of the cells which are there in stroma, loss of a lamellae, the collagen fibers getting distorted or they lose their strength. And this causes some sort of a response to cause weakening of stromal tissue. And once weakening is there, there's a bulge in happening and conus will happen. And actually, as I said, it will cause a visual disturbance in these patients. So basically, it is a central or a paracentral part of the cornea which is affected most often. And slowly, in advancement of disease, it will involve the entire cornea sometimes also. So it is a multifactorial association of various factors which lead to the keratoconus. So as I said, there may be a genetic factor also. There will be an environmental factor, hormonal changes, and ultimately there are biochemical changes in the corneal tissue to lead into keratoconus as such. Let me briefly take you to the genetics or a genetic involvement in these patients. As I said, there will be a 5 to 20% cases may have a history of family history of a keratoconus. In those cases where you have a family history, the first degree relatives has a almost 15 to 60% higher chances of developing keratoconus in their generation or siblings. Higher in the cases where you have marriages happening in the relatives, especially first cousins, which is quite common in the Asian countries. And we have seen that it occurs in the monozygotic twins. Both will have keratoconus. Some sort of genetic disorders, as I talked about, syndromes like Down syndrome, Leber's congenital amaurosis, or Ehlers-Danlos, where keratoconus is very common. And there are various genes which have been picked up in a keratoconus patient, which are associated with disease keratoconus. They would have an impact not in a diagnosis, but may have an impact on an actual treatment by looking into various genes associated in these cases, especially looking into antioxidant enzyme related genes where anti-inflammatory treatment may be effective in these cases. The future is on a genetic association, looking into which type of genes are affected and their treatment can be directed in those cases. The second important factor which I talked about was the environmental factors, which is also very important in a country like ours. We know that eye rubbing is a very common phenomena seen in the keratoconus patients, especially those people who have ocular allergies. So if you have a patient who has a habit of eye rubbing or who is rubbing the eye regularly, there are 60 to 80% higher chance of having this history in a keratoconus patient. So there's a definite correlation between eye rubbing and keratoconus happening in these cases. Ocular allergy also, there are almost 27% higher chances of keratoconus in these cases. Geographical pattern also, hot and dry climates like in Asian and Middle East countries will have higher chances of keratoconus happening. So as I said, eye rubbing will cause mechanical trauma. Eye rubbing will induce release of inflammatory mediators, and the ocular allergy will again, people will be rubbing their eyes. So basically, this environmental factor will lead into a damage to the stroma because of oxidative damage. There will be an increased protein degradation happening in these patients, the loss of stromal collagen fibers, and actually weakening of a cornea happening in these patients. Similarly, contact lens use is also associated with allergy with contact lenses, or a rigid contact lens per se has been implicated as a development of keratoconus, or we are not sure if these patients had a predisposition of keratoconus as such. But yes, any foreign body which causes allergy will have a higher chances of a history of rubbing, inflammation, and development of keratoconus in our patients. So eye rubbing and the allergies will have a higher risk factor for a keratoconus development. What about the actual change happening, which are biochemical factors? So basically, it is two things. One is immunological response and inflammatory response, which leads into keratoconus disease per se. So you have a change in a cell function because of oxidative stress, which we call about. which will actually antioxidant atrophy happening because of decreased antioxidant in these cases, which will be causing eye rubbing. The immune cell activation and secretion of inflammatory cell mediators, which will again act onto the corneal collagen. The raised cytokinins will again affect the biochemical metabolism of these cells, and that will actually alter the cell membrane in these patients and cause protein dearrangement, and collagen fibers will get distorted. So this is a complex phenomena happening because of a genetic predisposition, because of environmental factor, because of allergies, eye rubbing, which ultimately causes biochemical changes, which causes a weakening and subsequent development of keratoconus. The entire process is multifactorial, and it is important to understand this also, because that will also lead into a treatment in these cases. Hormonal changes can also be associated. We know that that this disease is suddenly seen in a pubertal area where a lot of hormonal changes happening. If people have a pregnancy, there will be a definite change happening in the cornea. Many people have a progression of disease at that time. Similarly, the raised T4 levels in keratoconus patient can also be associated in that. The hormonal changes also play a part in a keratoconus also. So this was the basic pathogenesis of keratoconus and the prevalence part, which I covered. The other important thing people to understand is who are those people who have at a higher risk of developing keratoconus. Not everybody will develop keratoconus. It is 1 in 2,000, 1 in 5,000 person might have keratoconus. So this is the latest article, again, meta-analysis, where they picked up 6 important association or risk factors where you have a more chances of keratoconus. I think you should understand this. As I said, ocular allergy or eye allergy, where you would have a higher chances, at least 1.5 times higher chances of developing keratoconus than the normal person. Eye rubbing, which may be because of allergy, or as such, you have a 3 times higher chances of developing keratoconus. People having asthma, eczema will again have a higher chances. And the more importantly, family history of keratoconus in the family will again be at least 6.5 to 7 times higher chances of developing keratoconus in those population. Then consanguinity, which I talked about. So these are important history which should be taken up in the families, and population wise also. You should know these important things: consanguinity history, family history of keratoconus, any allergy also is an important part. So normally, as I said, it starts at the puberty, that is around between 13 to 20 years. Progresses next 10 to 20 years, which is a progressive stage where the treatment has to be targeted as soon as possible. Or eventually the disease will go, as I said, it's a very slowly progressive disease, would stabilize after a 3rd or 4th decade of life. There's a very rare instances, it would progress much faster in the older population. So how do we diagnose these cases? So there are 3 important aspects of diagnosing disease, which is also important for a keratoconus also. One is the history of patient. They'll come with a definitive history, which might indicate patient may have a keratoconus. Then we'll examine the patient to see if there's any findings which will pinpoint the diagnosis of keratoconus. Then we can do certain investigations which will either prove the diagnosis, or it can detect the preclinical features of that disease so that it can be picked up before the physical signs comes up. So there's the importance of investigation have to be done in these cases. The biochemical weakening are picked up by all these investigations, which is very difficult to pick up by clinical examination. So we are looking for those instrumentation equipments where we can detect this disease before the actual symptoms or actual physical signs come in a cornea. So we call it a topography or tomography in these cases. If you see, there are 3 pictures I put it here. One is a simple topography, which scans the anterior part of the cornea only. Then you have a tomography, it's like a CT scan type of picture, where you have a cut section of a cornea can be seen from the anterior to posterior part of the cornea. So it gives you entire detail of the corneal curvature, thickness from the anterior to posterior. Then you have a device which can actually assess the mechanical back strength of a cornea also. So if you have looking into a sensitivity of these instrumentation equipment. So if you reach up to a device which can give you a tomography as well as the basic strength of cornea, the disease pickup is faster before actually you could see the physical changes happening in these cases. So this is very, very important for a public to understand. Not everybody would require a tomography test to be done. So who are those people where if you come to the hospital, you should ask for a tomography to be done in those cases. So if you come with a history, family history of keratoconus in your family or in your maternal side or paternal side, and if you have a little bit of distortion of vision, or you have a repeated change of glasses happening, especially myopic number, then you should ask for a tomography test to be done in those cases. If you're suffering from an allergic eye disease, and if you have an eye rubbing as a history, you should always get tomography test to be done. This will give you a chance for a physician to pick up your disease early enough. So as I said, distortion of vision, allergy, family history is an indicator for a tomography. But if you're suffering from keratoconus, you have undergone some treatment, this is the device where we can check for progression or what is happening to your eye with the keratoconus also. We have picked up this disease disorder much earlier than earlier we had, because we didn't have these devices. Thankful to a procedure, laser refractive surgery, where these equipments are compulsory. And the basic idea there is to use the equipment is to pick up the preclinical disease. Therefore, we can prevent these people undergoing refractive surgery, because refractive surgery, laser refractive surgery, would also weaken your cornea. And if you already have a risk factors, you might develop the secondary keratoconus. We call it a post-LASIK ectasia in these cases. So these are 4 or 5 points are very important for people to understand. What are the presenting symptoms that people come to us? If you see this diagram on the right-hand side, there's a normal letter which is seen by normal people. This is early keratoconus, distorted, and there's advanced keratoconus. Things are absolutely distorted. So early correction can be done with glasses or contact lenses. Advanced cases require various other things like double vision, nearsightedness, or a repeated change of glasses, especially a requirement of cylindrical power with the change in the axis of cylindrical power is very, very important. And some people come with a difficult night driving, glare, and photophobia also. Complications are quite rare in the keratoconus because it is normally there will be a break in the posterior part of the cornea sometimes, and the fluid can seep into a cornea, which is quite rare, but you will see some patient coming with that also, directly coming with a hydrops or a swelling happening in the cornea. So normally some are picked up by optometrists. When people go for a change of glasses, simply by refraction procedure, they can pick up the keratoconus disease. But these are a stage where already patient has developed keratoconus. These are various clinical features which normally we see for our patients. The hydrops, which is not very common for a keratoconus patient, but it is much common in younger patients, especially with a history of eye rubbing and allergies. So it is a very, very important to pick up those high-risk cases and treat these patients as early as possible. There are certain risk factors of hydrops or a fluid getting into the cornea with a rupture happening in a deeper part of the cornea. Younger patients, eye rubbing and allergies will have higher chances of happening these patients. Basically, I like to give a brief on our staging so that subsequent people can have easy way to talk about treatment. There are various staging systems based on a keratometric or a curvature of cornea, thickness, and the refractive corneal scarring. So we normally grade them early, moderate, advanced, and severe. Depending on that, we can plan the surgery. So early cases or moderate cases, you'll hear from Dr. Namrata Sharma. We'll be doing a cross-linking of corneal collagens to strengthen the cornea and decrease the progression. These patients can also be treated with the contact lenses also. Advanced cases would require a surgical intervention. And some cases we can manage with the new generation contact lenses also, where we can avoid surgery in these patients. The corneal transplant surgeries are a last resort in these cases, because even after corneal transplantation, you may require contact lenses rehabilitation in these cases also. Just to summarize, as I said in the beginning, we have a higher prevalence in an Asian country like India and Middle East. It is a multifactorial disease. The basic association of genetics, protein damage happening to the collagen fibers, and structural damage happening in the cornea, which causes thinning and conical shape of the cornea. Physically, eye rubbing and allergies are very common association with keratoconus, and most severe cases will have faster progression. They are younger patients. Younger the patient, more is the progression of disease. And family history is a very important aspect to be checked in these patients. Early diagnosis, treatment is a very, very common. Future-wise, genetic analysis, as I talked about, for early detection. And we are all working on artificial intelligence as the base for early diagnosis and the treatment in these cases. We all know once you develop a keratoconus, so you have to live with this disease. It cannot be reversed totally, or cannot be cured as such. So our idea is to detect as early as possible before the physical damage happens in the cornea, so that we can preserve your good quality of vision and good quality of life. Because once the distortion has occurred, the distortion cannot be made into normal as such. The basic idea is to understand disease and pick up early enough where we can preserve your vision quality. And the last and most important part is the counseling of people, especially with family history in the family and the people who have developed keratoconus as such, and rehabilitate them not only visually, physically, and other socially also in these cases. And surgery, as a last thought, we like to avoid as far as possible surgery in these cases, because we have so many treatment modalities which can avoid surgery nowadays in more of these cases. Thank you for your kind listening.
Thank you so much, sir. I think that was explained so well to the public, the diagnosis and the epidemiology and the risk factors, that I'm sure there will be no doubts. We have a huge crowd on the YouTube and the Facebook as well, which we are told from our by Mr. Sunil, who's managing both the portals. I would now request Dr. Rajesh Sinha to give his talk on Intax in keratoconus. Intax is done for moderate cases of keratoconus. And following this, we will be talking about collagen cross-linking.
Thank you, ma'am, for this opportunity. And I'll be talking about a very specific and specialized treatment for keratoconus. Now, as very nicely has been explained by Professor Tityal, sir, that keratoconus is a disease wherein you have a conical protrusion of the cornea becomes steep. So the idea is to flatten it. And that is why these Intacs are segments, arc-like segments, as you can see here. These are made of PMMA, polymethyl methacrylate, and these are inserted in the peripheral part of the cornea so as to cause a flattening of the central part of cornea and to correct the myopia and astigmatism associated with keratoconus. Now, just briefly, I will tell you how it works. Basically, this is the a segment which is inserted into the corneal stroma. So it separates the corneal lamellae. It is inserted at the level of 70 to 80% of depth. And what it does is, as you can see here in the picture down, that it shortens the arc length. So it shortens the arc length of the cornea within the intact segments. And that is how it causes flattening and results in correction of some degree of emmetropia in keratoconus. I'll just show you a small video clip how it is done. The center of the cornea is marked. And once you mark the center of the cornea, this is the femtosecond assisted creation of tract. So within the cornea, you have to create a path through which you can insert the ring segment. And that is what is done either with a mechanical separator or by the use of laser, which is femtosecond laser, as it is being done here. So as you can see here, the path is being created. And this is a radial incision that has been made through which these intact segments are introduced. So the first initial part, it is the path is separated by a separator. And once it is done on both sides, then you place the intracorneal ring segment into this track, and it is progressed forward. So on one side it has been done. And then the same way it is done on the other side. And after doing both this, I'm extremely sorry for this. After doing both the sides, you put a suture to close this incision. And then in cases of keratoconus, you debride the central part of epithelium within the area which is there within the intact segments. And then you do cross-linking. A detail of cross-linking will be discussed by Dr. Namrata. And this is how it looks like in the post-op period. These are the intact segment. And what happens that the central arc length is shortened. So it is flattened, and thereby by flattening it reverses the steepening that is there in the disease called keratoconus, and thereby bringing about some correction in the emmetropia created by it. Just a few words about the planning of the surgery. It depends on the type of cone. Cone can be centered cone or decentered cone. If you have a centered cone, then in that case, you put symmetric segments. And if you have a decentered cone, you put asymmetric segment, means the segments are of different thickness so that you create correction differentially. Just an example, a case of -4 diopter sphere and -4 diopter cylinder at 40 degree. So in order to decide about the incision, you convert it into positive cylinder form. So -8 diopter cylinder with +4 diopter, -8 diopter sphere with +4 diopter cylinder at 130 degrees. So the incision will be put at 130 degrees. So here is the incision. And since the posterior float shows that the cone is central, you can put a symmetric cone. Another example, you can see here the float is showing that this is an asymmetric cone. And in such cases, it is better to have a differential treatment. So you put a thicker segment, you put an asymmetric segment. So a thicker segment is put here and a thinner is put here. So as to create a differential treatment and correct astigmatism. Sometimes in an asymmetric cone, you also put a single segment. Like in this case, a single segment has been put. This is the incision, and this corrects the irregularity that is seen in cases of in corneas, in cases of keratoconus. So in conclusion, intracorneal ring segment is a specialized treatment which is done in cases of keratoconus to regularize the surface, to flatten the central part by inserting one ring segment and flattening the central part of the cornea. And it is combined with cross-linking so that once you regularize the surface by putting the ring segment, you can stiffen the cornea by use of corneal cross-linking. And that's how you bring about the visual rehabilitation by further means, by contact lens, etc. But you correct a significant degree of emmetropia, particularly astigmatism in cases of keratoconus by intracorneal ring segment. So thank you very much for your patience.
So thank you, Rajesh. I would now be speaking about the collagen cross-linking. So I would be talking to you about collagen cross-linking in corneal ectasias and surgery. And the corneal ectasias, like has also already been discussed, can be primary, that is keratoconus, where you just have a cone, or can be keratoglobus, where you have the whole of the cornea which becomes globular, or it can be thinned out in some parts and not thinned out or curved out in other parts, when we technically call it pellucid marginal degeneration or Terrien's marginal degeneration. Alternatively, even it can occur after surgery. So it can occur after various refractive surgeries, as has been shown here, and after corneal transplantation procedure also. Now, this has already been covered, so I will not be covering this. Basically, I'll be talking to you about collagen cross-linking, which is the treatment modality for progressive keratoconus at early stages. And this is a procedure which stabilizes the progression of the disease It has excellent safety profile, which has been proven in adults. And now there are many studies and literature in the last 10 years or so to establish that it is a safe procedure and it is an efficacious procedure. Now, it is important to understand that collagen cross-linking halts the progression of keratoconus. Whatever keratoconus is occurring at whatever stage it is, it cannot treat it. It just prevents further progression. So if we look at the normal corneal stroma, there are collagen fibrils or bridges which are present in between. And in keratoconic corneas, there is distorted arrangement, as was very nicely shown by Professor J.S. Tityal sir. And also there is reduced tensile strength. So what we are planning to do, or what we aim to do, is increase these crosslinks so that the cornea becomes more stable. So riboflavin excitation is done and photoactivation is done with the UV light. So it releases reactive oxygen species. New covalent bonds are formed, which increases the biomechanical resistance of cornea by more than 330%. Now, it can be done only in some cases of keratoconus. It cannot be done for all cases of keratoconus. And we generally do it when there is a progression in keratoconus, although there are some situations in which we will do even when the documentation of progression is not there. So like has been shown previously, the patient undergoes corneal topography, and whenever there is a change in keratometry value of more than 1 diopters over 1 year, or in cylinder of more than 0.5 diopters, or when there is corneal thickness which decreases over a period of 1 year more than 20%, then collagen cross-linking is indicated. However, if your cornea is very thin, less than 350 microns, or if there is a scar present, or if it is severe dry eye, or immunocompromised patients, or other diseases like collagen vascular disease, or history of poor wound healing, or riboflavin allergy, then in those cases, we cannot do collagen cross-linking. This is again to show the same. What is initially done is that you debride the epithelium, and after debriding the epithelium, the riboflavin is instilled, following which the UV radiation is given. This is essentially, you can say, it is actually not a surgical procedure. It is just radiation followed by preceded by epithelial removal, which is just the skin of the cornea which is removed. Now, there are various protocols that we follow, and I think this is too technical, but these protocols are followed depending upon the indication, depending upon the surgical time that is there. And this is again briefly to show you how it is done. So this is the skin of the cornea that is just removed. And then after this, the riboflavin, which is yellow in color, is instilled. And this is so that the UV radiation can occur on the cornea, and also so that the deeper layers of the cornea are protected. Now, after this, the UV radiation is given. And even when the UV radiation is given, this is just to show that riboflavin drops have to be given. This is followed by the application of the bandage contact lens at the end of the surgery, following which the patient is discharged. Now, generally, we can tackle with one eye, and we generally do the worst eye first, provided that the corneal thickness is adequate, followed by the fellow eye, which some people like to do it after some gap, and some people like to do it together. Now, after collagen cross-linking, it is important that you do not rub your eyes at least for the initial 5 days. Then you may notice that there is increased sensitivity to light and there is a foreign body sensation. Patients may also notice that there is discomfort. If there is any severe pain or sudden decrease in vision, one should immediately contact the treating eye doctor. And if the contact lens falls down or becomes dislodged, then one should not replace it, but you should immediately contact the treating doctor again. And it is important to know that there may be some discomfort during the healing time, when it takes about a week for healing to occur. And there may be some foreign body sensation, gritty sensation, or burning sensation. Generally, we can do conventional cross-linking, but some of the corneas which are thinner, you may have to do different kind of a procedure where we do cross-linking, but we use various aids, like we would use a riboflavin dye, which is hypoosmolar and not isoosmolar, or we would do a contact lens assisted cross-linking to increase the corneal thickness thickness, or several other methods like donor cornea assisted cross-linking. Now, I think I would not go into the details how these are done. Suffice it to say that we increase the corneal thickness by various mechanisms and then do the cross-linking. Now, it has been shown that there would be corneal flattening of up to 1.4 diopters or even up to 1.7 diopters in some of the studies. In an odd case, there may be also increase in the curvature of the cornea, but by and large, there would be flattening. And in the initial part, there may be corneal thinning, but later on, it becomes quite stabilized. Collagen cross-linking procedure on an average would last you for about, say, 6 to 8 years, because the collagen turnover is about 8 years. Some of the cases you may not need to repeat, but again, in few cases, say in about 10% of the cases, you may have to even repeat the procedure. In the follow-up, you give antibiotic drops, lubricants, then bandage contact lens is removed on day 3 or 4, and then follow-up is generally done at week 1, month 1, 3 months, 6 months, 1 year, and then yearly thereafter. In children, we would like to follow up at a shorter interval. And when you're also monitoring for progression, for children, you again would want to follow up at a shorter interval of 3 months as opposed to 6 months, which we do in case of adults. Now, when there is thinning, which is there extensively, the patients are contact lens intolerant, there is presence of corneal scar or corneal opacity or whitish cornea. In cases of keratoconus, then you may have to resort to corneal transplantation. Corneal transplantation is something that should be deferred for as long as possible, because that requires a lifelong follow-up. And this is just to show that some of the cases you can do the partial replacement of the cornea. So only the, not the entire cornea, but only say about 250 microns of the cornea is removed and replaced with 350 microns of the cornea. So the total becomes a normal thickness cornea, which is about 500 microns of the cornea. And this is sutured with the 10-0 monofilament nylon sutures after removing the diseased cornea. Now, at times when it is really thinned out, you may have to go right up to the edge and remove almost 90% of the cornea, but still about 10% would remain, and you would do a procedure which is outside the eye and not enter the eye. This is just to show the pictures when the sutures are still there, and after removing the sutures, only thing that you see is a suture line there, and there would be no sutures. Now, when it is very severe, you may have to remove the entire cornea and replace it full thickness, as is shown here. But this is done in very severe cases, as has already been described earlier, that you can have mild, moderate, and severe keratoconus. You can again have pellucid marginal degeneration, where the thinning and the curvature changes only peripherally. So that can be treated with contact lens or with Intacs or with corneal transplantation. Now, this is just to show that thinning was present only in this part. So this part is only being reinforced, and the rest of the cornea, we are not trying to reinforce, except that we are putting a partial thickness cornea. And this is how it will look after putting the sutures, because the peripheral part of the cornea is also thinned out, apart from the central part of the cornea, which is thinned out in keratoconus here. This is to show how when you have a whitish cornea, you may have to replace it completely, because you may not get past this whiteness after you do a partial thickness replacement of the layers. Now, something that we are doing, and I'm sure Dr. Praveen will also be talking about this, is the biosynthetic cornea, in which a pocket is made with the help of the femtosecond laser. And then this bioengineered or biosynthetic cornea is taken, is folded inside, which looks very much like a contact lens, and then is placed inside. And this procedure does not have any sutures at all. So, and this is followed by the bandage contact lens placement. So we've actually tectonically stabilized the cornea, because we've added thickness to the cornea. And additionally, you can also cross-link it so that it does not progress further. Again, after a corneal transplant, you would give antibiotic drops, steroids, lubricants, and follow-up. Follow-up is almost lifelong. And also you may need to follow up more frequently for removing the sutures. So to conclude, as far as collagen cross-linking is concerned, one must understand that it halts the progression of keratoconus. It is done when corneal thickness is still adequate, more than 400 microns, and repeat procedure may be required in about 10% of the cases after 8 years. It also depends on what time you are having collagen cross-linking. If it is done in a child, for instance, you may require a repeat procedure. But if it is done, say, at the age of 20, 21 years, you may not require repeat procedure. If thinning is not adequate, then different protocols can be used and different methods can be used, which is more for us to know, especially the technical details thereof. And in cases of excessive thinning, severe ectasia, and whiteness of the cornea, corneal transplantation may be done. This can be partial thickness or this can be full thickness, depending upon where the level of opacity or the whiteness is. So thank you very much for your kind attention. So we would be taking the questions in the end, and I would now request Dr. Himanshu Matalia to come talk to you about a very important aspect, and that is visual rehabilitation after keratoconus.
Thank you, Dr. Namrata. Am I audible?
Yes.
Yeah. So when we talk about keratoconus, this is how we like to treat the keratoconus, where based on the location of the cone, whether the cone is centered or whether the cone is decentered. And as the previous speaker said, that if there's a progression in keratoconus, we would like to stop the progression. Ultimately, whatever we do, the ultimate goal is visual rehabilitation. Interestingly, the treatment of keratoconus includes certain things which makes doctor happy, which is stabilization of the cone. As a doctor, we would be really happy that, wow, we have stabilized your cone. But as a patient, the other person may not be happy until the visual rehabilitation occurs. So the visual rehabilitation is done using different modalities, and few of them we actually already discussed. So my job is relatively simple, where I just have to tell where exactly we can use these things. Things like contact lens, a PRK, topo-guided PRK or intracorneal ring, and phakic IOL are the majority of them which we will be talking about. So when we talk about the visual rehabilitation and contact lens, the simplest treatment is contact lens. Now, contact lens, where does contact lens fit into the entire thing? Well, it fits when the cone is very advanced and when the cornea is irregular. And if we are able to do a cross-linking in this cornea, we surely should go ahead and do cross-linking and then use the contact lens. Now, if the contact lens, if the cornea is not thick enough to do the contact to do the cross-linking, we can still use contact lens till we go for the definitive treatment, like how Dr. Namrata said, corneal transplantation. So where contact lens fits in, well, most of the time, in most of these cases, we can actually fit the contact lens. Let's take, my talk would be based on cases, so it's more easy to connect with the subject. Now, let's take this young lady who had come for cross-linking. And on examination, initially, we saw the corneal thickness was 384 micron, which is low, but still not impossible to do cross-linking. However, when we did an NTA segment OCT, we found out the corneal thickness was not, the true corneal thickness was much lesser. And in fact, the corneal stromal thickness was even less. It was like 206 micron, which may not be the best case to do collagen cross-linking. Such kind of case, we can do visual rehabilitation using scleral, mini scleral, or any advanced contact lenses. The advantages here, it's non-surgical advantage. Well, it can visually rehabilitate patient very fast. And if it progresses later on, we surely can do a corneal transplant procedure. So all these things we would evaluate based on effectiveness of the treatment here, which is very effective and nothing can give better vision than that. Technically, well, it may require somebody who is trained in such kind of contact lens trial. Though it's not very difficult. Usage-wise, well, it can be used for multiple corneal condition, hence very useful technique. And is it value for money? Of course, it is value for money. So what do we learn from here? Well, newer contact lens can be fitted in advanced cases of keratoconus also. The best visual rehabilitation can occur with a good fitting hard contact lens. And very advanced cones, be aware that you may end up miscalculating corneal thickness based on only certain diagnostic procedures like Pentacam, and hence you might want to use anti-segment OCT there. Coming to the next thing, intracorneal ring implants, which Dr. Rajesh Sinha already elaborated upon. Hence, I don't need to tell you anything in detail, but where does it fit into our scheme? Well, where the cone is centered, or it's decentered also, where we can use asymmetric ring, but the cone is centered and with low spherical equivalent. That means the power is relatively low. And there we surely can use intracorneal ring implant following the cross-linking by stabilizing the cornea. The treatment is very simple, but where is the role of Intex? If you can see on the right side, a cone which is pretty significant, by using a ring becomes much more localized in the center, and progressively it becomes much more regular surface. And such kind of thing can give very good vision even with the glasses, or in worst case with contact lens. Sometimes the outcomes are so good that very advanced cone, we can make it relatively okay and can give you good vision with either contact lens or even glasses. Sometimes the vision improvement may need a contact lens on top of it. Where it works best is cases of post-LASIK ectasia. One such case, 30-year-old female who had LASIK history and had post-LASIK ectasia, underwent intracorneal ring implant along with the collagen cross-linking. And as you can see here, from quite significant ectasia, the surface became much regular, and at the end, patient had very good vision outcome, as well as the surface was as if there was the regular LASIK done. So a single ring, as Professor Sinha was showing earlier, can actually give quite significant vision outcome and quite rapid visual recovery in such kind of cases. So how does it fit into our scheme? Well, effectiveness of treatment wise, moderate to mild keratoconus, it works wonderfully well, especially with the low spherical equivalent. However, the outcome may not be very predictable. So we cannot predict that you don't need to use glasses or contact lens. We cannot offer such kind of outcome. Technically, it's very simple procedure, but sometimes planning requires an experience, and the person needs to be a little more experienced about that. There's no other usage for this procedure other than keratoconus and post-LASIK ectasia. Hence, it would be limited to such kind of condition. Value for money, well, the cost can be sometime inhibitory factor for a certain patient, but if we have a femtosecond laser, this is certainly a procedure which can be considered. So what do we learn from here? Where intracorneal ring implants or Intex can improve quality of vision in especially mild to moderate keratoconus. Especially if they have low spherical equivalent or low power, it can give very good vision outcome also. It's really best treatment for post-LASIK ectasia. And if you already have a femtosecond laser access, this is certainly a treatment which you can consider in your armamentarium. The next treatment modality is phakic intraocular lens. Now, where does it fit? A cone which is relatively centered, which is stabilized using cross-linking, and for the visual rehabilitation, we can consider. It's very simple treatment, easily reversible, and gives you very good quality of vision. And it's extremely useful in cases of keratoconus with myopia or keratoconus with relatively high power. First, it has to be cross-linked these corneas. And after waiting for probably 6 to 12 months time, but the cornea is stable, we surely can think of a toric phakic intraocular lenses. There are quite a few of them in market, and we are spoiled with the choice in our country. Let's take an example. A young male who had keratoconus, who had undergone cross-linking and intracorneal ring implants 2 years ago, had relatively stable ocular surface. And if you can see, the cone also was looking quite nice and central, and had a significantly high spherical and cylindrical power. Such kind of case can be quite decent case for a phakic IOL. And as you can see from here, the surgery is done under topical anesthesia. 2 side ports are made and under either viscoelastic or under irrigation with the saline, we can insert a phakic intraocular lens inside the eye. When we combine following intracorneal rings or intakes, sometimes the visibility may be a little bit affected, but we can turn the eyeball in different direction, and which can still give you a decent visibility. Of course, the treatment is simpler, where we just have to tuck the lens behind the iris and remove the viscoelastic, and the surgery is over. Overall surgical treatment is very simple, and vision outcome is really nice. If you can see from here, from pre-op, significant amount of glass power to relatively quite low refractive error, and a quite significant improvement in overall quality of vision, this patient was really happy. So does it mean that everybody we can use such kind of lenses, even though the case here looks very central cone? And I was quite happy to offer this procedure to my patient. But when we evaluate this case further, we realize that the topographic axis, what we can see from here, which is very intuitive and very normal, which looks like 70-degree there, was not correlating, was not matching with the refraction axis, which was far away from there, which was 20-degree. So when there is a mismatch between the objective assessment of keratoconus and the subjective assessment, this may not be the best treatment to offer to the patient. Also, beware that falsely deep central anterior chamber in keratoconus can fool you. As you can see from here, more than 3 millimeter anterior chamber depth in such cases, which is required in keratoconus cases, sometimes can falsely be present due to just ectasia in the center. And in such cases, we may end up in crowding of the chamber and maybe ultimately a glaucoma. So where does it fit into our scheme? Effectiveness wise, well, it's best reserved for regular and central cone, so it cannot be done for every cases. Sizing can be an issue, so the surgeon needs to be aware of how to handle these things. Technically, it's very simple procedure and can be performed by any cataract surgeon also. And other usage wise, well, it can be used for myopia, hyperopia, and many other things. Hence, phakic IOL is certainly a procedure which can be used by many surgeons. Value for money, well, it certainly does not require any special infrastructure or instrument. Hence, it's certainly value for money. So what do we learn from here? Well, the phakic IOL are best reserved for central cone, especially with the high spherical equivalent. It works wonderfully well. However, beware where topo and refraction do not match, or central anterior chamber depth may be sometimes misleading. We can also use toric IOL in advanced cones or central cones, which are relatively stable, or which are later age group, as Dr. Tityal was showing, that later age group, it does not progress much. So one such case, we are talking about a relatively young male who had very high myopia and with keratoconus, and required a corneal, required a cataract surgery. Underwent a cataract surgery with a customized toric lens with 4.5 diopter cylinder and minus 12.5 diopter spherical power. Post-operatively, patient had excellent vision outcome and patient was very happy. So in certain cases, where can we use these toric lenses? Where there is correlation between manifest axis and topographic axis, or where the cone is relatively asymmetric, but using the intracorneal ring implants, if we have made it relatively regular, in such kind of cases, we can think of using it. So where do we fit in our system? Well, effectiveness of the treatment, it's best reserved in certain cases. Not every case of keratoconus we should use toric IOL. Technically, it is relatively simple treatment and any cataract surgeon can use it, but requires little more experience, especially in complex toric IOL calculation. It can be used, the toric IOL can be used for any regular cataract surgery. So it's certainly useful technique. Value for money wise, well, it does not require any special infrastructure, and hence certainly value for money. So what do we learn from here? Toric IOL are best reserved for central cone, especially when topo and refraction are not matching, not use that, and selected cases would be the best use for that. Topo-guided partial PRK. Coming to the cornea, which are relatively irregular, we can regularize the cornea by treating with topolizer and loading it to our certain laser platforms, which can regularize the surface and can make the cornea much better. So if the cones which are relatively central, we can reduce the cylindrical power there and can improve the quality of vision and quantity of vision after the cross-linking. And when the cone are decentered, we can make the cornea more regular and can possibly visually rehabilitate them using a simple treatment like glasses, contact lens. So preoperatively, a cornea like this, which are relatively irregular, by treating with the laser post-operatively, we can make it quite regular and which can be visually rehabilitated using either glasses or even the soft contact lens also. So overall, a quite exhilarating outcome by improving the irregularity on the cornea. And it can certainly be useful in selected cases where especially corneal thickness is good. Technically, it requires a little more experience in planning, but it's a very simple treatment. The same platform can be used for other refractive surgery. And if the LASIK machine is there, which is compatible for such kind of topo-guided treatment, certainly a good treatment. So what do we learn from here? Well, the good pachymetry cases where somebody with a good corneal thickness, where we are able to get repeated and reliable topolizer or aberrometry readings, where with maximum ablation around 50 to 60 micron, more of the cylindrical power than spherical power, we can regularize the cone and it can be certainly a very good treatment. If the cornea is irregular or a very advanced cone where the contact lens are not fitting, previous speaker spoke about the corneal transplantation. And we surely can do a corneal transplantation, especially the deep anterior lamellar keratoplasty, where we do not change the inner layer of the cornea and just change the stromal layer of the cornea. And these kind of cases would eliminate the chances of rejection, still giving a very good visual outcome and giving a long-term benefit for the vision to the patient. The corneal transplant in such kind of cases can be done using different techniques. The one which I'm showing here is using the femtosecond laser and making a mushroom shape cut, but it certainly can be done using any vacuum trephine or normal trephine also. The overall treatment procedure is not very complex, but does have little learning curve, and which possibly with the with the multiple platform and teaching webinars available is not very difficult for everybody. Overall, where does it fit into our protocol? Well, effectiveness of the treatment is very good, but it certainly requires some kind of technical expertise. With the complexity of the procedure, you do need some training. Also, somebody who wants to perform should have an organ transplant act certificate or HOTA certificate. It can be useful for many other corneal diseases. So if you get an expertise in this thing, it certainly is very useful. Does not require any special instrumentation. So it's certainly a value for money. So what do we learn from here? Well, it's best reserved for very advanced cone and still has a little learning curve. And it's for trained cornea surgeon and requires long-term follow-up. So finally, to summarize, the keratoconus is treated based on laterality or the central, rather centration of the cone, whether it's centered cone or decentered cone. Once we stabilize the cone, and then the visual rehabilitation can be achieved using different techniques. and case selection is absolutely mandatory. Thank you very much.
Thank you, Himanshu. I think that was very informative. I will now ask Dr. Praveen Krishna to speak on what is new or innovations in keratoconus.
Thanks, Namrata, and thanks everyone for your excellent overview of keratoconus so far. So I thought I'll probably follow up with some interesting insights that we learned about keratoconus, more from the perspective of how prevalent or how common this disease is, and what we've seen and learned in the last 30 years, and what to expect going forward. So what I'm going to be sharing with you right now is the data that we've analyzed that we've seen that is more common than before. You've also heard from Professor Titial about the epidemiology and how common keratoconus is getting, especially in the Indian subcontinent. So I won't be covering that, but also would be important for us to pay attention to why the future might be. So just to summarize some of the important findings is the fact that the prevalence of keratoconus seems to be on the rise. That is, we're seeing more and more patients with keratoconus from what Professor Titial shared with you. And keratoconus is common in certain geographies and ethnic groups, seems to be much more common in the Middle East and in the Indian subcontinent. And also it seems that these ethnic groups are more susceptible to developing keratoconus. It also seems to be appearing at a younger age in Asians, and we've been seeing patients who are as young as 7 years with keratoconus, but the most common age group as of now is the early teens. And interestingly, data from India is still limited about how frequent keratoconus is. So the data that I'm going to show you is collected from our network of 210 centers, mainly based at Hyderabad, but also in the 3 states of Telangana, Andhra, and Odisha. Again, when we looked at the total distribution of the different problems of corneal diseases that came to us, we found that about 11% of all patients who had corneal disease had allergy, and about 7% of all patients who had corneal problems came to us who had keratoconus. Then we also looked at the number of patients who had corneal blindness, and also the number of patients who required keratoplasty or corneal transplants. And we found that of all the patients who are blind or who had very poor vision, 7% of them had very poor vision because of the keratoconus that they had. So over the last 30 years, we looked at about 20,500 patients, and we found that the majority of these patients were male. And in fact, 2/3 of these patients were male, only about 1/3 were female, showing that keratoconus is much more common in males as compared to females. Another interesting insight we found when we divided the keratoconus that we saw in the institute into 5-year blocks was the last 10 years accounted for the majority of patients whom we've been seeing, which means that the number of patients of keratoconus has actually shown an exponential increase. And about 70% of all the patients that we've seen in keratoconus, males, females included, we've seen in the last 8 years, compared to about 30% in the 22 years before that, which means that keratoconus is becoming more frequent. Interestingly, we also found that the average age at which patients who have keratoconus come to us earlier in the 1980s and 1990s was about 29 years, but now this has come down to 22 years, which is also showing that keratoconus is presenting at a much younger age as compared to what it was earlier. We also looked at what kind of interventions we do for keratoconus over the last several years. And like you see, the blue line shows the total number of interventions or surgical procedures or any procedure that we do for keratoconus. And obviously, the line is very steep because the number of patients are more. But in general, you see that contact lenses seems to be one of the commoner methods in which we manage keratoconus. Cross-linking is seeing an increase in the numbers, but we'll look at that data a little more carefully. So if you divide all the interventions and look at which patients are getting what, it still seems that the majority of our patients are still being fit with contact lens, even in the last 10 years or so. So the majority of patients are visually rehabilitated with contact lenses. A small proportion undergo corneal transplants, but a very large proportion, especially in the last 10 years, are undergoing collagen cross-linking as a stabilizing procedure. When we looked at the contact lens usage pattern of keratoconus patients, we found that there is an increase in the percentage of patients who come to the clinic who are using contact lenses. And this coincides with different kinds of specialty contact lenses that have been released. And in fact, we've seen that some specialty contact lenses like scleral lenses have increased the number of patients who are wearing or who are using contact lenses quite comfortably at this point of time. The average age at which patients start using contact lenses from the 1990s to now has really not changed very much. It seems to be just about the same. When we talk about surgical procedures per se, excluding contact lenses by percentage, we still see that in the last 10 years, there is an increasing percentage of patients who are undergoing collagen cross-linking, like Dr. Namrata shared with you, and lesser number of patients are undergoing transplants or penetrating keratoplasties, which is a good thing, which means that we are able to detect and also stop the disease earlier by doing cross-linking rather than subjecting these patients to corneal transplants. There is a procedure that we also briefly seem to have a rise, which is called intracameral perfluorinated propane gas, or C3F8, which we started doing in 2007, following a publication from our institute, and this became very popular. But then again, it started coming down with time, and we don't see as many acute hydrops, which is a complication of keratoconus, potentially because of the fact that we seem to be cross-linking a lot more than before. The other interesting aspect is if you compare the percentage of cross-linking with corneal transplants, like I shared in my earlier slides, you still see that the cross-linking percentage of all patients that we do is going up quite significantly, and there is a smaller proportion of patients undergoing corneal transplants. So this potentially is because when we started doing cross-linking in 2007, we found that in 2008, only about 0.5% of patients are undergoing cross-linking, but now about 6% of all keratoconus patients are undergoing cross-linking. That translates to about 1,300 cross-linking procedures that we are doing per year in this 5-year period, which is quite significant from the point of view of surgical intervention. So the age at which cross-linking is being done is also younger and younger. Earlier cross-linking, the average age was closer to 20. Now the average age is closer to 18 years. So we are actually cross-linking patients earlier than what we used to do in about 10 years ago. When we're looking at corneal transplants, we find again very interesting trends that the total number of lamellar keratoplasties, that includes the kind of keratoplasties we do most commonly for keratoconus, is actually going down over the last 10 years. And then when we look at the proportion of full thickness transplants, which is in green, versus lamellar or partial thickness transplants, which is in gray, we find that the percentage of partial thickness transplants has crossed 50%, and that is the majority of kind of corneal transplants we do nowadays for keratoconus as compared to full thickness penetrating keratoplasty a few years ago. Another interesting aspect is as the number of cross-linkings have increased, we found that the number of corneal transplants have proportionately decreased with time, corresponding to the fact that cross-linking seems to result in less requirement of corneal transplants. The average age at which we are doing corneal transplants also has come down from 29 years to about 22 years, which is also quite interesting. So to summarize what we found from our data over 30 years, we find that keratoconus accounts for about 7% of all corneal disorders that come to the hospital and about 7% of all transplants that we do in the hospital. The incidence of keratoconus is rising over the last 3 decades, and the age at which keratoconus patients are presenting is getting lower and lower. Contact lenses and cross-linking seem to be reducing the need for transplants, and hopefully in the future, we won't need to do transplants at all for keratoconus. The other interesting aspect is also about the age. We find that the majority of patients with keratoconus tend to present between 11 years and 30 years, or more than 80% of patients who have keratoconus are actually in this group. And again, like I said, males have much more commonly have keratoconus as compared to females. When we also looked at the socioeconomic distribution, 91% of patients who had keratoconus were from upper socioeconomic strata, whereas only 8% were from lower socioeconomic strata. This potentially has something to do with geography as well, where we found that close to 50% of all our keratoconus patients were from urban areas, and about 65% were from cities or urban areas, and only 1/3 of the patients with keratoconus were from rural areas. The vision at presentation also, we found that there is a significant number of patients who had severe visual impairment at the time of presentation. So it is important to actually be able to detect keratoconus earlier than later. Another interesting aspect, like Dr. Kityal mentioned, is the fact that a significant number, 12% of all our patients had serious eye allergies at the time of presentation, which shows that allergy probably is a predisposing factor for keratoconus. And when we looked at our publication from LVP about what is the most common age for allergy, we found that the most common age of patients who actually come with allergy is between 3 years and 11 years, which is just before the age of onset of keratoconus. So eye rubbing is something that is very important, that is increasing the prevalence of keratoconus. When we also looked at the severity of keratoconus, with grade 4 being the most severe, grade 3 little less severe, grade 2 and 1 being milder, we find that keratoconus presents more in more severity in a bimodal fashion. That is, children who come to us between 0 and 20 years seem to have more severe keratoconus, and adults above 40 years have more severe keratoconus, but those between 20 and 40 have less severe disease when they present in the hospital. When we compared males and females, interestingly, though the prevalence of keratoconus is lesser in females, they tend to have more severe keratoconus as compared to males when they present to the hospital. And we also looked at where the area the patient is coming from and what kind of severity they have. It seems that patients who come from cities, potentially because they have easier access to hospitals, have less severe keratoconus at presentation as compared to those who come from rural areas and semi-urban areas. So to summarize again, 80% of keratoconus seems to occur between 10 and 30 years, and there is a male skew with 2/3 of all keratoconus occurring in males. It seems to be more common in the upper socioeconomic strata and in urban areas. Close to 15% of patients have severe visual impairment, so it is a serious problem that needs to be taken seriously. At presentation, females have more severe disease, and semi-urban and rural patients tend to present with more advanced stages of keratoconus, possibly because of access. Interestingly, in the next maybe 10 years or so, cross-linking and new varieties of contact lenses are going to be game changers for keratoconus. It is very important for increased suspicion in young patients with refractive errors or glasses that are not stable to be scanned for keratoconus. The key to preventing a lot of the complications in keratoconus is early cross-linking and monitoring to reduce the need for transplants. And again, in the future, keratoconus is not a disease that is limited to hospitals alone. It is very important for everyone to realize that this is a public health problem, and it's important to do community high school screening programs to ensure we pick up keratoconus early and also intervene early, because the number of years a child who has keratoconus has to live or deal with keratoconus is probably about 60 to 70 years, which is quite significant. And keratoconus is resulting in significant vision impairment if it is detected late. Thank you very much for your kind attention.
Thank you so much, Praveen. I think we summed up the entire thing, right from the epidemiology, diagnosis, collagen cross-linking, and the various flow charts which were shown by Dr. Himanshu, and then finally concluded with Dr. Praveen's 30-year analysis, which, gives so many insights into how keratoconus has evolved over the last 30 years. Almost when we all entered into ophthalmology and now when we are there. So thank you so much. We've had about close to 1,500 people on YouTube, Facebook, and we've had many congratulatory notes and thank you notes. And anybody wants to discuss something or say something? Himanshu, would you want to say something?
No, Dr. Namrata, I really appreciate your Herculean efforts about this thing, and we wish that we reach out to more number of people like this and under the umbrella of All India Ophthalmic Society. And I really would like to thank you and congratulate you.
So hopefully next year we will have it in a physical format. So thank you so much, Himanshu. Thank you, Praveen. We would like to thank Dr. J.S. Titial sir also and Dr. J.K.S. Parihar for consenting to do it under the aegis of all the cornea societies that we have in our country, along with the All India Ophthalmological Society, and hope to have more such issues and webinars on a public platform to increase awareness for the public and also for advocacy. It is being diagnosed more. The scare is also quite a bit that you should undergo collagen cross-linking. And if there are any questions, you would be happy to take them. You can always, we'll put up our contact email addresses of all the societies, and you can always ask on those. So we, on Facebook, YouTube, and Twitter, we will put it on all of them. So thank you everyone.
Thank you. Have a nice
Thank you,
evening.
Namrata. Thank you. Good night. Thank you.
Sir is there? He just came, I think, in the meeting.